Hello, my name is Daniel Tsarenko, and today I'll be presenting on the growing role of lung ultrasounds within the NICU setting. We will take a look at how this technology is really reshaping neonatal respiratory care, in improving diagnostic accuracies, and improving overall care for our most vulnerable patients. Our learning objectives for this presentation will be to identify key lung ultrasound patterns used in neonatal assessments or during the neonatal assessment, differentiate between common neonatal respiratory conditions, how they look and appear on the lung ultrasound, and exactly what we are looking for, explain the advantages and disadvantages of lung ultrasounds, and finally, we will take a spin at applying lung ultrasound findings to a particular case scenario. So let's get into it. In the recent years, lung ultrasound has rapidly grown within the NICU setting, really all around the world. Unlike chest x-rays, lung ultrasounds are radiation free, they are portable, they can be placed right at the bedside, they can be repeated as often as needed without any additional risk of exposure or radiation. And for premature infants and critically ill infants, who may require multiple daily assessments, this makes lung ultrasound a great bedside tool in comparison to the chest x-ray because it provides immediate real-time information that is available to the clinicians, and with that information clinicians can quickly start respiratory support and tailor it with much more precision than they can with just a normal x-ray. Now, although chest x-rays have been the traditional method for assessing lung diseases, they do have several limitations. Infants are exposed, like I said, to radiation over the course of their NICU stay, and positioning them for imaging can be very stressful for both the babies and the clinicians that are having to position the babies. X-rays are also provided, or they also only provide a single snapshot in time of what the lungs are currently doing, and the results of these can be delayed until they are officially read by a radiologist. And even then, interpretations can vary between differing providers. So lung ultrasounds really help to address all of these gaps that are formed by the chest x-ray. They are safer, they are more dynamic, and they're able to be really reliable in terms of assessing the patients. Lung ultrasounds work a little bit differently in neonates and in particular the lungs than ultrasounds used on other organs. Because the lungs are filled with air, ultrasound does have a very difficult time directly imaging them. And instead, the lung ultrasounds, they heavily rely on things called artifacts. Now, these artifacts are visual patterns created when sound waves interact with air or fluid. So it's not directly looking at the actual tissue that is around it. Just on that, you're kind of almost seeing through it, but you're just seeing these artifacts. And really understanding these artifacts and being able to recognize them during the scan is the key to reading these types of scans. And these types of artifacts include things like A lines, B lines, you can see consolidations, the pleural lining, any abnormalities with that, and these are all things that we will go over during the course of this presentation. And these patterns correlate very strongly with specific respiratory conditions, allowing us to look at these scans and to diagnose and monitor different types of diseases right there at the bedside. So the first artifact that we will take a look at, they are called A lines. Now, A, you can think of A equaling air. Air is good. This is where you want air. You want it within the lungs. So this is a good thing to see on an x-ray. A lines are these horizontal repeating artifacts that appear beneath the pleural line. As you can see by this picture, that very top line at the very top is the pleural line that kind of goes across. And then the lines underneath it that are repeating, still those horizontal lines, those are your A lines. That's because, remember, you're not actually looking into the lungs because they are full of air, and lung ultrasounds rely heavily on that artifact aspect. This indicates normal, well aerated lung tissue, which is great. And seeing this in newborns is typically reassuring. And I say typically because A lines can also appear in the presence of a pneumothorax, because again, that is air within the lungs. And so if you are noticing that there's an absence of lung sounds, patient is decompensating, there's no lung sliding, there's other ways to determine if it's a pneumothorax. This is definitely one of the ways, so context is very important when analyzing these. The second artifacts are called B lines, which B means fluid. They couldn't call them F lines for whatever reason, so they went with B. B lines are these vertical comet trail artifacts that extend from that pleural line that we saw before all the way to the bottom of the image. In neonates, B lines indicate increased interstitial and alveolar fluid, which is very commonly seen in transient tachypnea of the newborn, in early RDS, and in pulmonary edema, conditions where there are fluid elements at play. Although some amount of B lines are normal within a scan of an infant's lungs, because they still have fluid within their lungs that they are kind of working out and getting out. So it's typically very normal to see B lines within a patient scan, but it's when they are a lot more numerous and tightly packed that they can indicate significant lung diseases. Typically, anywhere between 3, 4, or more B lines means that there's clinical significance of a particular disease. Then the clinician just looks at the distribution of these B lines, the density of these B lines, to help differentiate between the different types of respiratory conditions. So that can really easily help to determine whether it's RDS or TTN, transient tachypnea of the newborn, which is what we will take a look at here in this next slide. TTN is one of the most common causes of early respiratory distress in neonates. The lung ultrasound typically shows bilateral B lines, as you can see from this scan, often with a finding known as double lung point, which represents the transition between normal and fluid-filled lung zones, as you can see by that arrow pointing. The pulmonary or pleural lining, will have some abnormalities as well and be a little bit jagged, as you can see there. But really, lung ultrasounds can very easily help us differentiate between TTN and RDS really within minutes. And this is really crucial because TTN is generally resolved on its own, while RDS requires a little bit more of targeted respiratory support. In this next slide, we can see what RDS looks like on the lung ultrasound. And as you can see, the findings are a lot more dramatic. The pleural line has become visibly irregular and it's a little bit more thickened. The B lines, there's so many of them, they're becoming very dense and compact and kind of fused together, creating what's called the white lung appearance. All small consolidations can be seen as well on this scan, and that's what RDS looks like. So as you can see, very easily able to determine the difference between these two respiratory diseases with a simple lung ultrasound, without causing any radiation to the baby. Lung ultrasound is also extremely sensitive for pneumothoraxes. A key sign to be looking for in this presentation would be the absence of lung sliding. So normally when you take a breath in and a breath out, your lungs kind of move, and so you're able to pick that up on a lung ultrasound. All of the images that we have seen so far of the lung ultrasound have been this very wide range of view, not very deep into the patient's scanning the patient, but just kind of more wide range. Well, the lung ultrasound has an option to switch it to M mode, which is basically focusing the sound into a very narrow beam that kind of shoots through to monitor motion. That's what that M mode stands for. And so a normal lung presentation will have this kind of seashore effect, as you can see from the image on the left, where you have kind of those waves that are coming in, and as those waves come closer, it turns into this seashore, and that's because there's movement there from the lungs from you breathing in and out, which is a good thing. However, on the right, if you see, it looks all like a barcode, no motion, no movement there. That means that everything is still. There's air between the lung, the pleural lining, so everything's just kind of standing still and you can't see that lung sliding, that indicates the presence of a pneumothorax. Of course, there are other clinical signs, so a judgment is required here as well. But what is very nice about this is that now you know exactly where to tap this pneumo, right? Because you're looking at this straight beam, and as you're navigating it and moving around, you can tap at that exact location and grab the pneumothorax and alleviate that, which is great. The clinical value of lung ultrasounds extend far beyond just diagnostic purposes. It can also help clinicians with deciding when to administer surfactant, assessing the effectiveness of CPAP and looking for less areas of consolidation during the whole course of the baby being on CPAP, and also help determine when infants are ready to be weaned from the ventilator or from other respiratory support. Because, again, it's safe to repeat, this really becomes a great tool to monitor the progression and improvement of different types of lung diseases in real time, which is a huge strength. But of course, despite its strengths, lung ultrasounds do have limitations. It is highly operator dependent. Accuracy does improve significantly with training and experience, but it still relies heavily on the operator. If you do not get your wand in the correct positioning, set the correct parameters, you're not going to get a great image, and you can't really do anything if you don't have that great image. It also cannot visualize deep structures that are hidden beneath well-aerated lungs. Like I said, you're not really scanning deep into it. You're really looking for those artifacts or kind of that surface level things. And so there's a potential to miss different things that a chest x-ray or a CT scan would pick up. Additionally, misinterpretations is always a possibility, but especially for those clinicians who are new to this or still in training or practicing with this or don't use it as often, they have the potential to misinterpret different things. However, through standardized protocols, specialized training, these challenges can very easily be overcome with time. So now that we have gone over that, let's apply it to everything that we've learned to this particular case study. A 32-week preterm infant presents with grunting and retractions at about 15 minutes of life. A lung ultrasound is performed at the bedside that shows 4 diffused B lines and several small subpleural consolidations. Because looking at this image, because there are more than 3 B lines and their consolidation there's consolidation there along with a little bit of that white lung sign that we were talking about before, this is is showing a high likelihood of like mild moderate RDS. And so based on these findings, the team then starts early CPAP rather than escalating a little too aggressively to intubation or anything else. After several scans over the next 2 hours show improvement in the patient, confirming that the infant responded very well to CPAP. The infant then stayed on that throughout the course of their NICU stay and was slowly weaned off. So great. You kind of saw that little bit of process of how that would work, what the clinicians are thinking through when they are looking at lung ultrasounds. As you can see, with practice, it definitely becomes easier to read and to react in a timely manner. And that's really the power of lung ultrasounds. They are safe, they're portable, they're fast, and remarkably accurate in diagnosing different types of respiratory conditions. It guides immediate interventions and allows clinicians to monitor changes in real time as well. And adopting this into your NICU would be a very powerful tool for any RT to use and to really help improve outcomes in the NICU and to fine-tune different therapies. Thank you so much for listening to this presentation. Here are my references, and if you have any questions, please feel free to reach out. Thank you so much.